All right, let's go back and watch this video on TEP.
I'd got cancer on the larynx, and it was a question of surgery because it wasn't responsive to radiotherapy. The small plastic valve is inserted between the esophagus and the lungs, so all the air goes through there, and it acts as a kind of a false vocal cord. It was a big shock after the operation. You just sort of think, God, well, am I going to be able to talk properly? Am I going to be able to live a normal life and cope with this? I think there's quite a lot of anxiety in oneself about that. It took me quite a time to adjust really psychologically and to learn the new routines and what I needed to do to take care of myself. And I must say the support I've had has been remarkable. It's made a huge difference. Whenever you're put in the picture clearly by medical people and who are sympathetic and nice, you feel much more able to take the whole thing on board. I was anxious that it might change my voice very drastically and substantially, so that I would, in a way, appear as a different person, and it would take people a lot of time to adjust to hearing me talking in that way. So it was a tremendous relief when I found that, in fact, it hadn't really changed my voice that much. I would say to people, yes, you can get your voice back. You have to believe it. You have to just sort of stick with it. That you do overcome, though, after time, you do overcome the shock to the system, and you can actually lead a pretty normal life again. So it's not as bad as it seems.
So there you saw probably a really great example of a guy using TEP for esophageal speech. So at the end of the last group of slides, I mentioned that as SLPs, we've gotten to the point where we're starting therapy, exercise programs before radiation, before surgery, and then during radiation, and then after radiation. And we're doing that to get the muscles in as good a shape as possible going into radiation, and then also to reduce the possibility of fibrosis from radiation. Fibrosis is the formation of microscopic scar tissue, connective tissue within the muscle that's not supposed to be there. And when a muscle goes through fibrosis, as fibrosis increases, the range of motion and the strength of the muscle decreases. So to combat that, we have exercise programs that we're putting in place where the person is working their muscles much more than usual, not allowing the muscles to form any fibrosis or to minimize it, and also to minimize the possible atrophy of that muscle that could also occur. Here is an example of one of those programs. I think this is the most well-documented, the most well-researched one, and it's called Pharyngosize.
Pharyngosize, which is an exercise battery provided at baseline to patients going through chemoradiation and looking at the outcomes associated with that, and in particular, looking at issues associated with adherence. So although we're able to see and define specific muscle change in terms of preservation of muscles associated with swallowing during the chemoradiotherapy period, adherence to all exercise protocols and a lot of self-help protocols by the head and neck cancer patients is limited. So anywhere between 55 to 30% of patients are not going to adhere to some of these directions. Because of that, we've been looking at ways of identifying reasons for non-adherence. And interestingly, in the latest data from our recent clinical trial of 130 is identifying a combination of fatigue and fear at baseline, preventing patients from doing self-help activities, in particular swallowing exercises. And we know that a proportion of patients are going to drop out of that kind of intervention by about week 2. And it isn't a pain-related phenomenon, but it is a fatigue and fear at baseline combination. So that's something that we're investigating. And I was able to show some data where fear was linearly related to the amount of total work performed.
So the word she was saying was adherence. It sounded, because of her British accent, took me a minute to grasp what she was actually talking about. But the patient's adherence to the exercise program, it's not good for for a variety of reasons. Probably depression going into the cancer treatment. She said some degree of fear, just probably a lack of motivation. And I think after the chemoradiation treatment, probably some degree of pain as well. So the Pharyngosize program uses a relatively standard combination of exercises, falsetto glides, so starting low, and coming down. So doing a lot of those, doing a lot of tongue presses where you're having the patient push against something, probably a tongue depressor, hard swallows, using the hard swallow as not so much as a compensatory strategy, but as an exercise. So you sit there, maybe take a sip of water, maybe just do a dry swallow, and you really bear down and swallow hard. It's also a compensatory strategy. We're going to get to that later, but hard swallow or effortful swallow is also a strategy we use in the realm of exercise. Also, a mandibular strengthening system that is known as Therabite system, and that's what you see in this photo here before I covered it up. We're going to get back to that in a few slides. So what the Pharyngosize program looks like is 10 repetitions of each exercise during each cycle, 4 cycles per session, 2 sessions a day, 5 days a week for the first 6 weeks of radiation treatment. So you can understand why there's not such great compliance or adherence to the program, because that is a lot of exercises. Here's a score sheet that allows the patient to keep track of how much work they've done in the Pharyngosize program. All right, so we've talked a lot about dysphagia resulting from radiation, but we really haven't talked about what the actual changes are from the radiation that causes the dysphagia and what the dysphagia actually is. So let's start getting into that. You could have mucositis, and this is a inflammation of the mucous membrane in the oral cavity. So there may be sores, ulcers, xerostomia. We've mentioned this. This is a dry mouth problem. You could have changes in your taste and smell, and this is very common in people who have undergone radiation or are going through radiation. Fibrosis, which we've already discussed, which reduces range of muscle, strength of muscle, and hardens the muscle to the touch. Like that muscle will feel very hard. It can feel rock hard. Neuropathy, which is nerve pain from whatever area of the head or neck that has had the radiation. You can have certain changes in anatomy as a result of radiation, such as a esophageal stricture, which is basically a narrowing of the esophagus. There is a term called odonophagia, and this means just generally pain during a swallow. Patients going through chemoradiation can lose appetite. They can have swelling, which is edema. They will be more predisposed towards fungal and bacterial infections. And as we said, dental changes, such as your teeth rotting out. So here's an image of an individual experiencing xerostomia. So you can, looking at that person's tongue, you can imagine how difficult it is for them to take food successfully. A common fungal infection, candidiasis, or more commonly known as thrush. This is an fungal infection that occurs in the oral cavity, usually on the tongue. You can see it here. It's quite common in the patients that you see in hospitals. It's treated with antifungal medication. So as an SLP, that's not so much something we deal with other than to alert the medical professionals. The dentist play a large role in radiation in monitoring the oral health of patients before going through and then after radiation to try to preserve the teeth as much as possible. We already said the development of fibrosis is a major problem, and that can also be due to damage to the capillaries that supply blood flow to those areas of the muscle, and therefore those areas of the muscle that aren't getting enough blood flow experience some necrosis and form scar tissue. So it could be fibrosis as a direct result of the muscle getting hit by the radiation, damaging the muscle, or fibrosis can also occur in secondary fashion, in which the blood flow to the muscle fibers are being restricted. Following radiation therapy, patients can have a significant degree of weight loss because of reduced oral intake, meaning they're not eating as much for all these factors that we just mentioned. Also, there is an increased chance of aspiration and penetration due to difficulties managing the bolus. Xerostomia, it doesn't affect the patient swallowing so much as it affects their perception of their swallowing capability. And you can imagine how having a dry mouth would make swallowing more effortful. It would make bolus formation more effortful, but you could probably manage it appropriately with a cup of water. Following radiation treatment, the changes in smell and taste that a patient experiences, sometimes that is permanent, and that's not good. But hopefully, normally, usually, the taste sensation, smell returns to normal. Now, that being said, sometimes patients still have an aversion, learned aversions to food as a result of their experience, their changes in their taste as they were going through radiation. One possible problem following radiation as a result of fibrosis to the muscles of the mandible is trismus, also known as lockjaw. And you track the patient's range of motion, their mandibular range of motion, meaning how much they can open their mouth using what is known as the Therabite ruler. And all patients need to be able to open their mouth at least 35 millimeters. So let me show you an image here that will probably stick with you of trismus. So this is an old film of a patient being treated for trismus. The patient is going to be knocked out, and you're going to see the doctor sort of wrench his mouth open. You can see he has reduced range of motion. If he's only able to open his mouth that much. So patient's being knocked out. The doctor is now going to sort of wrench his jaw open. And this is done in an effort to try to restore range of motion. As you can imagine, you're just tearing that muscle fiber again. So you're probably creating lots of micro lesions in the muscle tissue, which is just going to possibly set the patient up for more fibrosis. But if this happened and then that was followed up with exercises to manage the fibrosis, then maybe that would be a good thing.
Still want to talk to you a little bit more about my treatment. When I had my surgery, they removed 6 teeth on the left side, and so later down the road, I had to have an implement, a denture. I think they call it arbitrator or some big long word. I call it a denture. But before I could have this denture made and have the impression, I had to be able to open my mouth to 25 millimeters. That was my target in order to be able to get an impression. Now, when I started all of this, my mouth had...
So what she's talking about, what she's calling a denture, I believe is going to be some sort of prosthetic device, maybe a palatal lift or a palatal obturator, and you can hear her hypernasality. So that the prosthetic device would address that.
Locked down. I couldn't get my finger between my teeth. Now, some people, they have a bigger medical name. I called it TMJ. Meant I was locked down.
For the record, it's not TMJ. Talking
We
about trismus.
tried several things. We tried using tongue depressors, and every day add another one, and do that several times a day. Wasn't getting me anywhere. Then there was another implement, I forget the name of it, but not important, that I had for a short period of time, and it really wasn't helping either. And now my oncologist, Dr. Murphy, discovered this deal. It's called XinoSplint, all one word. Very expensive. The cost was $5,000.
$5,000. So they are not cheap.
My insurance paid every dime. And I thank God for that. But I know in my heart that there are people that don't have insurance or a way to come up with the funds. That's another reason, in my opinion, that this Courage Unmasked, helping those who need the help, why it is so important. Now, this this contraption, if you will, I still I still use it twice a day. Now, I was using it 4 times, trying to get my mouth open. It took me 2 years, a little more than 2 years maybe, to get my mouth open far enough for the dentist to make that impression. So, but this dude right here, it helped me to be able to accomplish that.
So you can continue to watch the video. I think she models how she uses it. So that's the Dynaspent device, and there's also a Therabyte device. We're going to talk about a little bit in slides a little bit further down. So as you noticed, she mentioned that it took her 2 years of using that device to be able to open her mouth enough for the doctors, for the dentist, to take the impressions for her palatal lift or her palatal obturator, whichever one it was. So improvements to the trismus may occur very slowly over time, and trismus does affect over a third of head and neck cancer patients, so that's a lot of patients. And usually it's going to co-occur with pain with swallowing, xerostomia. So now looking at what the actual dysphasias are that result from all these problems that result from the radiation. Our patients with head and neck cancer that go through radiation, they tend to have bolus control deficits. They tend to have to form smaller boluses. They tend to use what we call piecemeal deglutition. And this is related to smaller boluses. Let's say you put a big spoonful of something in your mouth or a big piece of steak. Patient will chew it up and then they'll swallow a little piece of it, and then they'll swallow another little piece of it and another little piece of it. We call that piecemeal deglutition, holding the food in their mouth, holding the large bolus, but like pulling off smaller pieces, making smaller boluses to swallow. You can imagine that if you're eating that way, it's going to take you much longer to eat, so increased meal times. Swallowing more frequently as normal becomes more difficult. That is going to also contribute to increased meal times. And also you can imagine that if you have xerostomia, if you have pain when you swallow, if you had an altered sense of taste and the food doesn't taste good, then all that's going to contribute to you wanting to eat less, you wanting to swallow less.